Hi, everybody. I want to welcome everybody to a webinar series that we're putting together from the University of Chicago Medicine on bloodless medicine and surgical programs that we have established here at our institution. We're going to have a cadence of about every 3 months. We'll have a webinar. We'll talk about our program in general, and then we will highlight a particular program that is exemplary. And today we have the privilege of highlighting Dr. Pablo Sanchez's lung transplant program, one of the few people in the entire world who does bilateral lungs, that's lungs on both sides, without blood. So I'm going to start my slides. And okay. When we talk about bloodless medicine and surgery, a lot of people dabble in it, but there are very few programs that are really committed to bloodless medicine. And when we talk about bloodless medicine in the context of patients who refuse blood, even if that leads to an unfavorable outcome. And patients do that mostly because of religious beliefs, like our Jehovah's Witness brothers and sisters. How does an institution pull this off, and how do programs pull this off? Well, what we have found is that, technology advances, and as that technology advances, we adopt it to bloodless medicine. And as we use technologies, we also innovate. A key component of these bloodless programs are a multidisciplinary group of healthcare professionals that are committed and dedicated to helping this underserved patient population. For instance, in cardiac surgery, the surgeons are important, but perhaps even more important is the infrastructure around the surgeons, including anesthesiologists, cardiologists, nurses, intensive care professionals. And there's a certain amount of spirituality and acceptance that is needed in these programs as well. This is not something for people who don't understand that we may be taking care of patients whose beliefs we don't necessarily adopt, but we accept and we respect. And that's very important for the whole team to understand. And it's something that programs like ours have. And of course, the whole program has to be comprehensive and holistic, because when we take care of a patient, there's an entire spectrum of the patient's journey, not just at one episode of care, but throughout their lifetime. So this is the bloodless team at the University of Chicago. I'm the physician director. My name is Val Jeevanandam. You can call me Dr. J. Colleen LeBune is our executive director, and she's also the executive director of the Heart and Vascular Center. You have Maureen Wilson, who's a Jehovah's Witness, and she is the Bloodless Program Director. We have Lance LaBerge, who is also he's a nurse APN, and he's a Bloodless Program Coordinator. And we have Andre Bourgogne, who is our community outreach and consultant. So Maureen and Lance kind of take care of the workings within the institution, and Andre is our liaison between the institution and the community, and for people who are on this call like you. So we kind of started this program. Everybody, all the programs were doing it, but cardiac surgery really, and Heart and Vascular Center really stood out. And we established this program about 20 years ago. During COVID is when we really started to employ our director and our coordinators and make it an institutional imperative. And I'll just give you some statistics from the cardiac surgical side alone. This is 2024. In 2024, we did 12 transplants. And just to put that in context, the only paper or published report in the literature is from Cedars-Sinai, and they did 8 transplants over a 20-year period of time. And we did 12 transplants in 1 year. So it's by far, we are the most experienced heart transplant program in the world doing bloodless surgery. And what distinguishes our program is that it's not only the normal transplants, it's the complicated transplants that other people absolutely will not do that travel all the way to the University of Chicago. We've also done 9 LVADs. So LVADs are left ventricular assist devices. They are little miniature pumps that get put into the heart. The results of LVADs are almost the same as that of transplant. And most programs will not do bloodless LVADs because in published literature, 50% of patients have bleeding and require major transfusions. Again, we're the world's leaders in doing LVADs, having done 9 of them at the University of Chicago Medicine. We've also done 21 bypasses and 15 valves. And I think, again, they're not, we would love to do normal cases as well, and we do them extremely well, but we also do cases that come from other institutions that they will not do. We've done 7 complex aortic cases, including aortic dissections. For instance, last week, we did a patient who came from Duke University. They have a bloodless program, but this patient was on dialysis, had an acute aortic dissection, was unstable, and flew all the way from North Carolina for us to do at the University of Chicago, and she's going home in 7 days. This is the map of all the places, of all the states that have sent us patients over the last 5 years. This is not 2024 alone. And as you can see, we've had patients as far away from Hawaii, Alaska, California. We've done 27 states. The only states that we're missing are Maine, New Hampshire, and Rhode Island. So once we could demonstrate that we can provide this service bloodlessly, we then went ahead and expanded it past just cardiac surgery and heart and vascular to create a comprehensive blood center for the Midwest. So we are here in Chicago, and we really service a large area of the Midwest. And we're focusing on cardiothoracic surgery, GYN, neurology. There is a surgeon called Dr. Mohammed Biden, who's now coming to University of Chicago. We recruited him from Mayo Clinic, and he's one of the world's leaders in doing bloodless spine surgery. So he's going to lead that effort. We have oncologists who we have Dr. What's his name, Maureen? The person from oncology with the bone marrow transplant.
Dr. Peter Rydell.
Yeah, so Dr. Peter Rydell is a world's expert in doing bloodless bone marrow transplantation and managing the patients. And we have a large oncology program that can be delivered bloodlessly. Orthopedics and transplant is something that we're particularly proud of. Not only do we have heart transplant, and you'll hear about lung transplant, but we also have kidney transplantation, both from living related donors and from deceased donors. And we are also doing bloodless liver transplantation in the group of patients that can actually tolerate it. And we also do pancreas and islet cell transplantation. So if somebody has diabetes, there's a potential to cure your diabetes. So this really leads to a very, very comprehensive bloodless center. And what we will now do in our seminar is go and learn about one of the particular programs, which would be the lung transplant program. Before we do, this is the way to reach the bloodless team at University of Chicago Medicine. That's a line. And if it's not manned, it goes to voicemail. There's the paging number, or anybody can email directly to bloodlessprogram@uchicagomedicine.org. It goes to Maureen and to Lance, and they'll reach out and do anything that's necessary to help the patient seeking that particular type of care. So with that, I'm going to open it up to questions. Maureen, can you mediate, see if anybody has any questions?
Sure. If you guys, I'm sorry, for the attendees, if you guys have any questions, please put it in the Q&A, and then we will try to get to all the questions. This is any questions throughout the presentation, just put it into the Q&A. So one of the questions is, how hard is it for patients to access care at UChicago Medicine? I know earlier, like Dr. Jeevanandam showed the map of patients coming from all over the United States, including Alaska. So how hard would it be for a patient who needs care to actually get care here at UChicago when they live out of state?
That's a great question. We make it as easy as possible to contact us. So all you have to do is email that address, or you can call or page, and we will get back to you immediately from a physician and nurse point of view. And then once we contact you, we would ask for your information and figure out if you are, properly treated at University of Chicago Medicine.
Okay, great.
That almost is the easy part. And then what we do is we will call you and set up a Zoom link, and so you can meet the team and you can meet the physician that's in the appropriate service line. That's the easy part. The difficult part is really going to be insurance coverage. And some insurances, if you have a commercial PPO, it's usually not a problem. If you have traditional Medicare, that's not a problem. If you have public aid, then we have to talk to your state public aid company, tell them that the service is not available in your state, and sometimes we can get an agreement. Probably the biggest problem we have is with these Medicare Advantage plans. We call it Medicare Disadvantage plans. If you're going to sign up for one of those plans, please make sure that it's comprehensive and that it allows you to seek care where you want to seek care. A lot of them are very, very restrictive and have very limited networks that you can actually access. I actually call it a Medicare Disadvantage plan. If you need to have care at our institution, sometimes if you're in the window, you can actually switch Medicare Disadvantage plans to the ones that we're in network with, or you can pop back out into traditional Medicare. But that is a program that you need to be very careful about. And that is our biggest problem in terms of supplying care. I will say that once people's insurances are clear, then they have to arrange travel, but we have some fantastic hospital liaison committee members. We have Guy Fuller and TJ Bullock and Bernard Williams, and they do an incredible job of finding accommodations and transportation and taking care of the patients once they come to Chicago. So it's your insurance. Once the insurance clears, access is very easy.
Thank you. There's another question. Is there a hemoglobin level where the risk would be too great to perform a transplant surgery? And what do you do to minimize that risk?
So what we do is, whatever your hemoglobin is right now, if you're a good candidate for transplant, we just admit you as an inpatient and we focus on anemia management and try to get that hemoglobin as high as possible. Our data shows that the best results are obtained with a hemoglobin greater than 12. The lowest hemoglobin I've done as a transplant is 8.5. And again, that was a very large person who was quite ill and couldn't wait for the transplant, had to be done. If your volume overloaded with a hemoglobin 8.5, that's actually a little bit good news because we can take the volume off and get the hemoglobin a little bit higher. So instead of having like a absolute cutoff for hemoglobin, if your hemoglobin is low, I would say contact us and we can figure out how to get your hemoglobin higher.
Yeah, great. Thank you so much. The other questions, we will answer them throughout the webinar if possible. If not, we will reach out to you directly if you are not anonymous.
Great. So it now gives me great pleasure to introduce Dr. Sanchez. So Dr. Sanchez joined University of Chicago about a year ago from leading the program in Pittsburgh. And he's recognized as one of the leading lung transplant surgeons in the world. And one of the things that really got us excited about recruiting him here is we were talking about our Jehovah's Witness bloodless heart transplant program. And Dr. Sanchez had already been doing a very similar program at Pittsburgh. What Dr. Sanchez did was, before he decided that he could offer this to a Jehovah's Witness patient, he wanted to be convinced that he could actually do these lung transplants without blood. So he actually wrote a paper, and he will discuss it, where he did 50 consecutive patients without blood. Now, they were not Jehovah's Witnesses, but they had the ability to get blood if they needed to, but he was able to do them without blood. The paper was published, his technique was published, and that allowed him the safety net, the confidence to be able to offer that to a Jehovah's Witness. And he did so in a patient that you'll hear from. This patient was one of the first patients in the entire world who got a double lung transplant. A lot of bloodless transplants are offered for single lung or for patients who are not so frail or not so sick. But because of Dr. Sanchez's experience and his development of techniques and technologies to handle patients without blood, he was confident enough to give this woman that type of therapy, and she's done magnificently well. So I'm extremely proud to be able to introduce Dr. Sanchez. The title of his talk is No Blood, No Problem, a Double Lung Transplant, University of Chicago Medicine. Dr. Sanchez? I'll run the slides, Pablo. Just let me know.
You know what? I made some changes, because I thought that it was important. So if you don't mind, I'm going to have to do this myself. Sorry about that.
Okay, I will allow you to. You should be able to slide. You should be able to do this. So I will stop the share.
Yeah, I think I just share my screen.
Okay.
So you should have my presentation up there. Well, thank you very much, Dr. Giovanna. You're way too kind. Because I'm not able to see my screen. You see mine? I just want to confirm that we all good. Okay, perfect.
I can see your screen.
I love it. Perfect. Thank you. So as Dr. Giovanna was saying, my introduction to bloodless surgery was not with a particularly objective other than improving outcomes in lung transplantation. And I'm going to walk you a little bit through.
Yes, sir. Thank you. If
you don't mind, Lance, can you mute yourself? So how do we get there? And I'll show you a little bit of what we did. So 1 second. There we go.
There you go. You got it. You're advancing the slides. It's working well.
Yep. Yeah. I had 2 screens, so I'm figuring out how this works. So how do we get to bloodless surgery? The first thing that I was part of was this multi-center study in which 20 lung transplant programs across the United States and Europe, we were providing data to this data center, and every so often we'll ask a question. And one of the first questions that we ask is, does the amount of blood that you get during your transplant affect your outcomes? And we divide that in 3 different thresholds, and you can see here, no blood, 2 units of blood, or more than 9 units of blood. And this is exclusively during the surgery, during a double lung transplant. And then we look based on the amount of blood that you received during the surgery, what were your outcomes? And one of the things, and I walk you through the most important thing. So one of the things that we realize is that if you look at primary graft dysfunction, and I'll talk about this a little bit in the next slide, in 3 days after the transplant, if you had received no blood, was around 9%. And if you had received more than 9 units of blood during the surgery, was around 30%, so 3 times as much. The probability that you will develop kidney failure, needing some dialysis, is around 5% or 20%. And the amount of time that you will stay in the hospital was around 27 days compared to almost 50 days. So based on these findings, and of course, this is not absolutely new literature, but it was a multi-center study, anything that we can do to reduce the use of blood in lung transplant can lead to better outcomes. So one of the outcomes that we are most interested in lung transplant is something that we call primary graft dysfunction, which means that right after the lung transplant, your lungs don't completely work well. And I put 2 cases here. You can see here on the top, and normally lungs should be black air is black when you do an X-ray. So the more black your X-ray, the better the lung looks. And you can see this is quite white. This is a patient who developed severe primary graft dysfunction, and eventually that cleared up. And this is a patient that did not develop primary graft dysfunction. You can see it nice and black, full of air lungs. And why is this outcome so important? Well, this endpoint is very important because in lung transplant, if you develop primary graft dysfunction, particularly severe primary graft dysfunction after transplant, has a significant impact in your outcome, not only in your immediate outcome, but also on how long those lungs will be good for after transplant. And I just showed you that if we reduce the use of blood during the surgery, we can reduce the development of primary graft dysfunction. So this was how the whole thing started for me. How can we reduce the use of blood? And of course, most of the literature that Dr. Jivananda already just touched a little bit on it is based on, bloodless lung transplantations in Jehovah's Witnesses. And there are a few centers across the world that have published that. But when you really looked at this data, it's either 2 patients that had a single lung, or maybe 20 patients, but 15 of them were mostly single lungs, or even our data from University of Pittsburgh, in which was mostly 2 patients, and those patients received the double. But these were very particular patients that were extremely well selected, and in which the surgeons did not anticipate the need of any hemodynamic support. So when you look at the literature in lung transplantation and bloodless surgery, in my opinion, this is what we had from it. It's mostly single lung transplants in extremely well selected patients without pulmonary hypertension, in which there was not anticipated need for hemodynamic support on cardiopulmonary bypass. But as you can imagine, this is a very, very restricted group of patients. And I showed you what, as a society in lung transplant, we're doing. And this is how the data in lung transplant looks. So as you can see, we started doing single lungs, but as the year have passed by, we're doing, a percentage of single lungs, but most of the transplants we do are double lungs. Over 75% of the patients that we transplant these days lungs are double lung transplant, because the outcomes and how long these lungs will live are significantly better, but also because we are doing more and more and more SEC patients. So there are patients which we cannot offer single lung transplants, and we have to offer double lungs. The other thing, as I just mentioned, we're doing more SEC patients, particularly patients over 70 years old. And you can see that surgeons across the United States and the world actually are doing, in the last 20 years, having increased the number of double lung transplant in patients that are over 70 from 5% to over 15%. So if we're trying to provide bloodless surgery, particularly in the setting of double lung transplant, because of the need of hemodynamic support of a more complex patient, the Jehovah's Witness data that had been published was not sufficient for us to get there. And that's how, at my previous institution, we started thinking, what is it that we're doing now that we can change and potentially do bloodless lung transplants for everybody? And this led to a lot of conversations. We got, of course, anesthesia on board. We got the ICU on board. We got a lot of people on board. And we looked at our intraoperative and postoperative practices. And this is the data Dr. Jivananda was referring to. Eventually we looked at our patient, as we can see that as an average, when we were using our previous protocol, we were transfused around 5 units. And when we established our new protocol, we actually didn't transfuse anybody. We didn't use any red cells, any plasma, any cryo. And I'll show you a little bit of what we did. I don't want to go into a lot of the details, but most of the changes that we did is that we use a version of cardiopulmonary bypass, which is ECMO, which is a much more compact system. All those hoses and oxygenators, they're all coated. So there is no need to use a lot of heparin. So we use a very, very, very low dose of heparin. Then we protocolize our cannulation strategy. We always cannulate the same way. We always flow the same way. we give during the surgery tranexamic acid, which is this particular compound that inhibits fibrinolysis, so kind of stabilizes all the coagulation factors. And at the end of the case, whatever blood that patient is in the system, we use for orthotransfer. We transfuse it back, and of course, we use the cell saver during the surgery. And by doing all these things, we're able to we were able to do 50 consecutive cases, all comers, no distinction, no differences if it was too sick or too healthy, if it needed a double, if it had severe pulmonary hypertension, or anything. Everybody went to the same protocol, and we barely used any blood. So when I came to the University of Chicago last year, of course, Dr. Jivananda was just saying that it's not just the surgeon wanted, and I was very lucky because they already had here a massive infrastructure under his leadership when it comes to bloodless surgery. So to me, it was just a natural transition to be able to establish that here. And recently, and I'm almost finishing, but recently we were able to do our first case, and I think you'll be able to see her. This was a patient that was 68 years old, and she had pulmonary fibrosis and moderate to severe pulmonary hypertension. She came to us at the time. She had been rejected by all the Florida and New York City lung transplant programs, and the reasons that they were giving her is that, well, for your age, you're too frail. You need a double lung transplant, and you need a bloodless double lung transplant. So when she landed, actually, she had to be admitted because, she needed quite a bit of oxygen, and she was frail, and her nutritional status was not optimal. But one of the things that we did was admit her. We evaluated her. We made sure that everything was, that she, independently what kind of surgery she needed, that she was a candidate. We defined that she was a candidate for lung transplant. She had to remain in the hospital because she needed so much oxygen, she couldn't go home. And during that period of time, which was close to almost 2 months, we were able, through intense rehabilitation and nutrition, we were able to improve her. We call this prehabilitation. We were able to improve her enough to be able to go through the double lung transplant. And I don't have a video, but I showed you some pictures of what a double lung transplant is and why sometimes, having surgeons agreeing to doing this surgery bloodless, it's a little challenging. It's a big surgery. We do this incision. It's called a clamshell. We go from one side of your axillary line to the other. We split the sternum in the middle. It gives us access to both your lungs, to your heart. And then we do something that is called sequential. So we transplant one lung at a time. So we take one lung out, and you can see this is the airway, this is the artery, and these are the veins here. And then we bring the new lung in, and we sew it in. And we start with the airway because it's the most posterior. And some people do the vein first or the artery first. That sequence doesn't really matter. And at that point, when everything is attached, then we start ventilating these lungs, and they come alive again. So that's pretty much how the double lung will look at the end. And I show you what happened to our patient. So when she came in December of 2024, when she landed, I think she was on 15 liters of oxygen, and eventually she had what we call an exacerbation. So she ended up in what we call high flow nasal cannula, so a lot of oxygen. I think she was from 15 to 70 liters, from 80% to 100% in FiO2. And remember, I mentioned that black is good when it comes to an X-ray. As you can see, her lungs were not really black, so not a lot of air. You can see all this white stuff. That's pulmonary fibrosis, which is pretty much your lungs are getting so scarred that they're not elastic, they're not compliant, they cannot transfer oxygen, and eventually the lungs become so hard that the arteries inside the lung get hard, and these patients develop something that is called secondary pulmonary hypertension. And now the right side of your heart starts struggling. And she underwent a surgery in February, and I showed you an X-ray of how she looks now. This is in May 25, so nice and beautiful lungs, and she's completely off oxygen. She's going back to her life, and we recently had a little bit of a press report. This is her, and this is her husband, which I found super funny that he's wearing a Chicago Bulls jacket. But anyway, so that's a little bit of what I can show you today, and I'm happy to answer any questions. Thank you.
So, Dr. Sanchez, one of the questions is while UChicago, like what made it so different for this patient to come to University of Chicago? I know you touched on it before. Why the patient was turned down at other centers was because she needed a double lung, and do most centers do single lungs and not double lungs? Like, is that what complicated it for her, which is why that was one of the reasons why they turned it down? Or what made UChicago stand out compared to the other programs?
Well, that's a good question. I think what made University of Chicago different is that we were willing to look at her case. We were, when a patient comes to us, we're looking for ways to say yes. I think that's probably what makes us different. So we say, okay, you're too frail. Can we do something to make that better? Or you need a double lung. You need a bloodless. What is it? What kind of expertise do we have here to provide you with that? Or you cannot go home. Well, then you need to stay in the hospital, and we have to do all that here inside the hospital. And I think, working through those little bit curveballs is what will allow us to get her to this point. I cannot speak of why other programs declined her. I can only speak, what she came to. I think we were her last hope. She decided to fly because she had no other options, and I don't think she expected us to say yes, actually, which is, it makes me happy that we did, because she looks amazing. And, but yeah, I think that's probably what made her experience here, the experience here different for her. We were willing to work with her, and we, the
Dr.
way she came to
Sanchez, I
us.
think you made a very important point, right? So where other centers find comfort in saying no, we find pride in saying yes. And we work very, very hard to be able to say yes. So when we looked at our heart transplant and our LVAD programs, we were able to offer therapy to 37 patients out of 40 referrals. So that's only 3 patients that, we couldn't offer therapy for, and they had different reasons why they couldn't have therapy, had advanced cancers or something else. But we work very, very hard. And in the literature, when other people are referred for like a heart transplant, only about 10% of patients end up getting a transplant. So we work very, very hard in trying to figure it out. I think, Pablo, you said it perfectly. It's like, we work hard in saying yes. It's not easy. And we all often have to do a lot of work before the procedure to be able to say yes. But we do take pride in saying yes. I think one of our biggest frustrations that Maureen faces and Lance faces all the time is that patients are followed in other institutions, and those institutions are just not honest with them, because they will not do them bloodlessly, but they won't tell them that either. And they end up getting worked up. They get all type of medical therapy. Then they start deteriorating. And then by the time they call us, they're very, very sick. And so it would be great if programs were honest with our patients, but they're not necessarily, they're not. And if patients, if you feel that your care is not optimal, or if you feel that you want to have any type of idea of a second opinion, we're very easy. Just call us. We can at least Zoom call you guys, and we can figure it out. Because I think the biggest shame that we face is that, we get called with a patient when it's way late, and then their post-operative course is much more difficult than if we had seen them earlier.
Absolutely. I think that's, it's what we take pride on, I think as a physician, particularly as a surgeon, saying no, it's so defeating that we, it took us 2 months to get her to transplant. So it was a lot of work. But when you see her, the way she came in, and when you see her now, you say,
well, you wanted us to see her, and
yeah.
It was great because Andre actually went to her house and interviewed her. And so we do have a video clip that I'm going to share. And I will start this video.
Hi, I'm Andre Burgoyne. I'm a consultant to the Bloodless Medicine and Surgery program at the University of Chicago Medicine. I'm here on site visiting with Teresa and Jose Victoria. This interview is important to us because Teresa is the first patient in Illinois to receive a double lung transplant done without the use of blood. She learned of Dr. Pablo Sanchez. He's the physician who performed this very complicated surgery at the University of Chicago Medicine. And so we thought it'd be nice to have some words with Teresa to see how she's doing, and of course from her husband, Jose, as well. So let's turn it to you. Teresa, tell us, when did you have the procedure?
Febrero 19, 2025.
Okay, that's just a few months ago. What are the circumstances that were surrounding your need for a double lung transplant?
Por 2 años yo empecé a perder la respiración y el doctor me dijo, el neumólogo me dijo que tenía fibrosis pulmonar.
Wow. Wow.
Esa fue mi causa de oxigenación.
You know, sometimes when we think about our patients coming in to Chicago, sometimes we might overlook the family. The immediate family in particular. Jose came with his family here to Chicago. She's going to be staying here for about 12 months. And so there's an impact even on the immediate family, not to mention her 6 grandchildren. Jose, can you tell us, when you learned of your wife needing to have this transplant, how did you feel?
Well, I was, first of all, I was too excited as she finds the hospital they're going to do the surgery. At the meantime, I was scared because they told us they're going to be a 10 street. And I was kind of confused, but at the same time, I was too happy.
When we look at Teresa, you're looking good, Teresa. I just want to say that. But when you learned you needed this procedure, what was your main concern?
Lo primero es, yo no quería transfusión de sangre. Esa era mi primera opción. Y como soy testigo de Jehová, mi prioridad es obedecer y serle fiel a Jehová. Y él dice que no sangre de ninguna forma.
Jehovah's Witnesses, for our audience here, have a non-negotiable position when it comes to receiving blood. And as she's highlighting, she's one of Jehovah's Witnesses, and she wants to adhere to that Bible directive. But so now, you hear about Dr. Pablo Sanchez from the HLC from Florida, connecting with the HLC in Chicago. How did you feel when you met Dr. Sanchez?
Bueno, cuando lo vi la primera vez, me dio mucha confianza, porque él me dijo que no tenía pendiente, que él me iba a hacer el trasplante sin transfusión de sangre.
So you found a doctor who is willing to do without blood. That's special because it's such a complex procedure. But all of us want to know now, Teresa, you had the procedure in February. How are you doing now?
Bueno, ahora puedo caminar, puedo bajar y subir escaleras, limpiar la casa un poco y sobre todo poder respirar con mis manos pulmones.
So Jose, let me ask you this as well. Now, you've come here, you've been assisting your wife, and notice how she's even doing more. She's even walking up and down the stairs, as she highlighted. How has your stay been here in Chicago?
Well, I don't like cold weather. I don't make choice. I don't be weather. My wife just take you to the brothers from the congregation. They have out of the department. They help me out sometimes with the food. We say that they come to my house, visit me. They never leave myself.
We're so glad that you all are having a good experience. being here. You know, they're from Florida, so you can understand why he has an issue with cold weather. But we're glad that you have your accommodations, so forth. So, Teresa, despite the adversities that you experience in getting here, undergoing the procedure, how do you feel now that you have received the double lung transplant?
Bueno, primero, estoy agradecida con Jehová que me dio otra nueva oportunidad y también poder pronto disfrutar de dar testimonio de su nombre, reunirme con los hermanos en la predicación, reunirme ir a las reuniones y sobre todo a las asambleas, que hasta ahorita me las he estado perdiendo, no puedo ir, pero yo sé que pronto ya Jehová me va a dar esta oportunidad.
We're so glad you could spend some time with us and with our bloodless community as well. So we're so happy, again, we could spend just a few minutes with Teresa. She's progressing well, as you can see. And we look forward to assisting others who have similar needs. We can see the beautiful outcome that she has. And of course, Dr. Pablo Sanchez will welcome any cases that could certainly use his expertise. Now, let's turn our attention back over to you, Dr. Jivanand.
Well, that was great. Great interview, Andre, and it was spectacular seeing the patient. You know, when we say, how is the patient doing? When we first saw the patient, I saw her in the ICU. She was on 15 liters of oxygen and could barely breathe. And to just watch her now, 3 months after her surgery, where she's not on oxygen, she's able to breathe. And I saw that beautiful sparkle in her eye when she said she could go to the assemblies and she was going to be protected by Jehovah. That's when she had that sparkle. And so it's really kind of spectacular. And we see this in a lot of our patients. And I think Dr. Sanchez did say, you know, we're usually the last chance. And it kind of gives us a little bit of a, you know, it gives us a little excitement, because a lot of times, you know, patients are told to go to hospice and there's nothing to do. And then they come over here and they get confused because we said, yeah, no problem, we'll take care of you. And lo and behold, a couple of weeks later, they're fine. They're not going to hospice. They're going back to a normal life. So that is something that we take a lot of pride in. So yeah, I think it was great. And again, if you want to reach the Bloodless team, here's the number to call, and be more than happy to take any cases. Doesn't have to be heart or lung. Could be any case that needs the expertise of being bloodless. Dr. Sanchez not only does lung transplants, but he also does thoracic surgery as well. So if anybody needs a lung resection or anything to do with the esophagus, Dr. Sanchez can take care of them as well. Maureen, do we have any other questions from the audience?
Yeah, we have a couple more. So one of the questions was, Dr. J mentioned the Bloodless program got started about 20 years ago. So they want to know why you became interested in Bloodless.
So actually, my interest in Bloodless started a long time ago when I was in Temple University in Philadelphia. And kind of because of two reasons. One was my father had open heart surgery. And after his open heart surgery, he had a lot of bleeding. And, it was in another institution. And I was up all night, milking his chest tube, making, praying that he would stop bleeding. And eventually he did stop bleeding. Then I was thinking to myself throughout the night, is there any way we can possibly do these surgeries where patients don't bleed? And of course, he did well for about 10, 15 years. But then when he eventually passed, my mom would always think that it was all the blood that he got that made him do poorly. And so even now, every single time I see my mom, she's like, you cardiac surgeons, if you just stop the bleeding, your dad could still be alive. So I constantly get that reminder from my mom. And so I sought to figure out how to do this bloodless thing. And right at that time, there was a drug that came on the market called aprotein that was touted as a blood that decreased bleeding after cardiac surgery. I was one of the lead investigators during the trial, and the drug actually got approved. And for political reasons, it came off the market. But with that drug, we could see what bloodless fields look like, what we could actually achieve in cardiac surgery. Because before that time, we just thought, yeah, everybody bleeds. After cardiac surgery just means bleeding. But after that drug, it showed us what not bleeding meant. And then even after that blood was taken off the market, after that drug was taken off the market, we knew what we needed to achieve to get a bloodless field. And so that's how I got interested in bloodless surgery. And it's a challenge, right? So as I always say, if anybody else can do it, that's great. But if people say it's not possible, that's when we get really, really interested. Because if we're just doing what everybody else is doing, then we're not really doing anything that's contributing to life. So, you know, as my mentor always used to say, you need to walk that fine line, because if you're not walking the fine line, you're taking up too much space. So it's a challenge. And I think we're like-minded at the University of Chicago, and that we all like challenges, and you know, we're damn good at overcoming them.
Thank you, Dr. Jivananam. This is for Dr. Sanchez. So, Dr. Sanchez, what are the usual indications for lung transplants?
The largest number of patients transplanted today are either pulmonary fibrosis and emphysema. But, you know, there are other indications like bronchiectasis, primary pulmonary hypertension. There are some other indications. I did also see, when is it in the questions, when will you seek an opinion on lung transplant? And since I have a few people here, if you have been diagnosed with pulmonary fibrosis, the diagnosis should trigger a consult with the lung transplant program. So we call that early referrals. Remember that there are a lot of things that sometimes we need to do to get you to a lung transplant or to a transplant in general. So the more time we have to work around those little kinks that everybody has, the better we can get you there, with the better outcome that we can provide also. So anyway.
Thank you, Dr. Sanchez. And then another question that came in is, can you anticipate the blood loss for a double lung transplant?
Well, ideally, the blood loss should be zero. So, I mean, of course, there are more complex situations. If you had, you know, the patient had previous surgery to their chest, or had a sequence of infections in their chest, so anything that will make taking the old lungs out more difficult, we anticipate that there's gonna be start bleeding. But we go, you know, imaging by CT scans already give us a perspective of how complex the situation is going to be, so we can plan around.
Great, thank you so much. Okay, let me see.
I was just looking through these questions. We can kind of answer them quickly. We have some time. One person said, I have lung disease and my lung is collapsed in the lower part. Does the doctor work with lung disease? Yeah, I mean, if you think that there's something that needs a surgical procedure or an invasive pulmonary procedure, just contact our bloodless team and Dr. Sanchez can evaluate your case. The name of the surgeon from Mayo Clinic is Dr. Mohammed Biden. Are any other types of bloodless transplants available, such as liver transplant? We do kidney transplants, both, and we do the living donors. We do them bloodlessly as well. We also do liver transplants in patients who have relatively low MELD scores. We do not do donor bloodless liver resections. And we do pancreas and islet cell transplants for people who have a lot of effects of type 1 diabetes. There's another question here about Eliquis for AFib. Now my client is having GI bleed from Eliquis. If the Eliquis is purely for atrial fibrillation, that patient is a candidate for a device called the Watchman device, which can close off the appendage in the left atrium and can allow that patient to come out off of anticoagulation. So if you want, you can either contact us or you can contact a physician that you are dealing with locally who can put in a Watchman device.
There's another question. What is done in cases where there is scar tissue from previous open chest surgery? I think Dr. Jivananam, you're an expert at this one.
Oh yeah, that is our biggest challenge. if the first time you do surgery, the heart is not connected to anything else and it's available to be operated on. If somebody has done some surgery, then that heart ends up becoming scarred, and it takes a long time to get that scar tissue off. Scar tissue usually bleeds, so we have to be super meticulous in getting it off. And the other problem, of course, is that the heart can get attached to the sternum, and when you open and you re-enter, you can actually injure the heart as well. So I guess my advice is, yes, we do reoperative surgery. Matter of fact, when you looked at our transplants, a third of our patients had previous surgery that we reoperated on. So that really does distinguish us in the cardiac side. But if you're going to have surgery, a lot of times what people will do is they'll do what I call kind of like Mickey Mouse minimal surgery. They'll, if you may need 3 bypasses and 2 valves. And instead of doing all that, they do 1 bypass and 1 valve, get you through the immediate surgery, and then a year or 2 later, now you need another operation to take care of the other things. So please, if you're going to have surgery and you're a Jehovah's Witness, get it right the first time and go to a program that will do the entire operation and prevent the need for reoperations. That's one of the things that I hate to do reoperations, so I do everything possible to prevent that from happening. You mentioned pancreatic transplant. It is not, transplants are not done for pancreatic cancer. Transplants are done for people who have diabetes and who need islet cells. And the islet cells are transplanted either from the pancreas directly, or the cells are isolated and injected into the liver. Has anyone done a bloodless heart and lung transplant simultaneously? That comes from Guy Fuller, one of our superstar HLCs. And Guy, our goal at University of Chicago is every year to do something that no one else ever done in the world. And we did do a heart-lung transplant, Dr. Sanchez and I, and that patient did not receive any blood. So we are now confident that in the right patient, patient who's not had previous surgery, et cetera, we should be able to do that. So we're looking for a Jehovah's Witness patient to do the first in the world bloodless heart-lung transplant. So we're ready. Okay. And do you do liver transplant in a bloodless way? So the problem with liver transplants is that the liver is the factory in the body that makes the proteins that cause blood to clot. So if the liver is not functioning properly, they have a lot of problems with bleeding. So, what people normally do for liver transplants is if somebody is in early stage liver failure, then those patients can get it done bloodlessly, and we do those bloodlessly in those patients. But if patients wait too long and by the time they come, they've had bleeding from their esophagus and their rectum and their bowel and their kidneys are bad, then it becomes too sick. So yes, we can do liver transplants as long as the patient is not too end stage by the time they present. All right, I think one more. Does your bloodless surgery program provide services for an 80-year-old with porcelain gallbladder that's suspected to be cancer? Again, contact our bloodless team and let us evaluate it. We do have some surgeons who are experts in liver surgery done bloodlessly. So if you contact us with the information, we can run it by them and see if you are a candidate.
Great.
All right.
Yeah.
I think that was informative. Dr. Sanchez, that was fantastic. Maureen, you were a great MC. And Andre, that was a fantastic interview. I'm afraid we're going to lose you to ABC News or something. But I want to thank everybody for spending this Saturday with us. And I will say that we would really appreciate your comments. And if you think that we could do anything to improve, or if you have any topics, please contact us and let us know. how we could improve, but we are expecting a cadence of about every 2 to 3 months where we would talk about our program in general and focus on a particular expertise program. And actually, Andres and Maureen are working on having a fall hybrid seminar where it would be in person with a Zoom option as well. So looking forward to hearing from you. And again, if any of your brothers and sisters have any type of disease process that needs to be done bloodlessly, please contact us with the Bloodless team, and we'll be more than happy to take care of you. All right. Bye-bye, everybody.